Welcome, and thank you for joining us today for day three of the Opioid Industry Document Archive's 2026 Symposium. My name is Kevin Hawkins, and I'm the Program Director for OIDA at Johns Hopkins University. On behalf of the entire OIDA team, we're so glad you're joining us for our third National Symposium. Please note this symposium is being recorded. Links to the recording will be posted on our website and shared to our email list. Before we begin, I want to note that none of today's speakers have reported any conflicts of interest relating to the opioid industry, UCSF, or JHU. The Opioid Industry Documents Archive, or OIDA, is a groundbreaking digital archive of documents arising from the opioid industry that advances understanding of the root causes of the epidemic and helps address corporate behavior that is harmful to public health. Winner of the Society of American Archivists Archival Innovator Award, and co-created by the University of California, San Francisco, and Johns Hopkins University, OIDA recently reached a 7 million document milestone, representing more than 33 million pages. The documents include emails, memos, presentations, sales reports, budgets, audit reports, Drug Enforcement Administration briefings, meeting agendas and minutes, expert witness reports, and depositions of company executives. The archive serves as a living repository of information that can be used to learn from the opioid epidemic so as to improve and safeguard public policy and public health, and to ensure that the opioid-related harms that have taken place never occur again. OIDA was created and funded in part through settlements of public interest lawsuits by states, and we would like to acknowledge the millions of Americans who have been personally impacted by the crisis, as well as to recognize the attorneys general and many other parties whose vision and commitment to transparency and accountability has made the archive possible. We strive to ensure that OIDA serves as a trusted source of information to help people understand the U.S. opioid crisis. We are developing this digital archive and its supporting resources for the benefit of the public, including individuals, communities, researchers, journalists, policymakers, and others affected by the crisis. OIDA and its services are freely available to all. I would also like to thank Amanda Norman, a member of the OIDA team who has worked especially hard to organize this year's symposium, as well as my colleague Kate Tasker at UCSF and the broader teams at UCSF and Johns Hopkins that are responsible for the archive's enormous reach and impact since its inception only a few years ago. Finally, I would like to thank all of you and all of the speakers that are participating in this year's events. The OIDA team is creating a number of resources to help with further exploration, teaching, and mining the archive. For example, in recent years, we introduced an opioid crisis timeline, a curriculum library, the OIDA data toolbox, and the OIDA image collection. These resources, as well as our research guides and recently released curated document sets, provide archive visitors with footholds and tools for research, data analysis, and other forms of exploration and discovery. Indeed, there are many stories to tell from the OIDA documents, from marketing tactics to abatement strategies to policymaking, and much more. We expect the archive to support research looking back at the crisis and helping to formulate systemic change to prevent future harms to public health. I now want to introduce Tanner Wakefield, an associate specialist at the Center for Tobacco Control Research and Education at UCSF, who will introduce today's panelists.
Hi, thank you so much, Kevin. My pleasure to be here today. I'm happy to introduce Dr. Claire Clark, Tracie Gardner, as well as Coryn Mayer. And we will first start off with Claire. Claire Clark is a historian of medicine at the University of Kentucky. She is a tenured associate professor in the Department of Behavioral Science in the College of Medicine and holds a joint appointment in the Department of History. She is the author of The Recovery Revolution, The Battle Over Addiction Treatment in the United States. And with that, I will turn it over to her.
Um, Thanks, Tanner. It's really a delight to be here. I am a huge fan of OIDA and the tobacco legacy documents at UCSF, although I haven't used them extensively in my own work. It's just a Herculean task what you all have done, and it is to the public good, the good of historians and future generations. And I am happy to be here and speak a little bit about from the perspective of history of health and medicine. And I think Amanda Norman has my slides. She's going to pull them up. Okay, thank you, Amanda. Yes, so happy to be here. Happy to to be with my esteemed co-presenters. I'm based in the University of Kentucky College of Medicine. If we could go to the next slide. Just a disclosure, as I said, I've not received any money from Johns Hopkins, from any of the opioid lawsuits. My institution now has an official view of institutional neutrality. I have to say, this is not the views of the University of Kentucky. I personally have received funding from the National Libraries of Medicine, Michael E. DeBakey Fellowship for the History of Medicine this last year, and talked about kind of the framework that I'm using to approach the history of medicine these days. And I also do serve as associate director for NIDA, National Institutes on Drug Abuse training fellowship. So training the next generation of multidisciplinary scholars and drug use research. My own positionality, I am a historian of medicine with public health training. I'm also a person in recovery, but I'm not a clinician and I'm not an activist. So I'm really, thrilled to be here with Tracie, who does the hard work of activism and public health and advocacy at the community level, and with Coryn, who is a nurse. But I'm not either of those things. But I, looking forward to being able to defer to them for their areas of expertise. Okay, so that's me. If we could do the next slide. I'm going to talk a little bit today, just give a little introduction about this new framework that is, you can call it a paradigm, you can call it a framework, whatever you might want to say. You can call it a wave of scholarship in the history of health and medicine that might be of interest to people who care about OIDA. And that's the reparatory history of medicine. So I'm going to talk a little bit about waves in the history of medicine, where this framework comes from, how the tobacco industry documents and opioid industry documents archives just raise the question of whether or not they might be considered reparative or reparatory projects. And I think that's an open question that I'd love to talk more about with Tracie and Coryn. A gesture to some future directions, some questions that we might ask of the archive, as it is thousands and thousands of documents large, but still being developed, right? So this story is very much still unfolding and still in progress. And one of the things that we learn to do as graduate level trained humanists is ask questions, ask open-ended questions. So that's what I'm going to do. Rather than, issuing any kind of proclamation. And if we can go to the next slide. Okay, introduction. So here is a picture, if we go to the next slide, of this past December. I had a fellowship in Boston to work on a project with my dear friend and colleague Deanne Ho at the Massachusetts College of Pharmacy and Health Sciences. We're working on a jointly authored biography of Henry Knowles Beecher, very famous figure in the history of bioethics, medicine, anesthesiology. And I had the opportunity to walk across the street to Harvard's Countway Library for the History of Medicine, which, though some 15 years into this career as a self-identified historian of medicine, I'd never been to the Countway Library for the History of Medicine. I was very intimidated, even at this mid-career stage, to go in there. And I signed in and I walked in and I went downstairs to look at some of Beecher's papers, and I snapped this picture. And this is, I think those are the archives of the Boston's Women's Health Collective. But this edited collection that I had the very good fortune to take part in, Do Less Harm, Ethical Questions for Health Historians, was sitting there on top of the Boston's Women's Health Collective archives. And I think that means that an archivist or a graduate student at the Countway Library History of Medicine was reading it. This was a career highlight for me. because ideally, this is what the production of historical scholarship is. It's a cyclical process, right? So the archivists have the papers, and we write the history, and then people read the history, and then that influences the archival collection. And a lot of the opioid industry documents are online, but I wanted to start with like the thrill of the archive and of going into the archive and doing historical research and holding history in your fingertips. This is what historians live for. And if you haven't had a chance to do that yourself, I would urge you to do it as part of your historical scholarship. And I would just say that there's nothing more thrilling both than producing knowledge that has stories that have never been told before, through your interactions with the archive, and then through writing those histories, shaping the stories that come next. And that's what it's all about. So, and really, a lot of this presentation will be, in many ways, a pitch for reading this book, Do Less Harm. And the chapter that I contributed with oral historian Amy Sullivan was about the names and the language that we use in talking about people who use drugs and writing those histories. But that was one of many, many chapters. But I feel like the book itself is kind of a gauntlet for a new way of thinking about the history of medicine. So, okay, so moving on. So that's just exciting to be in the archive and hold the books that are the building blocks of history in your hands. So we can go to the next slide. I'm going to talk a little bit about what came before the reparatory history of medicine. So if we can go to the next slide. And this is a huge gloss. When I teach my students, I talk about many different frameworks. So I talk about cultural history and scientific history and things like that. But I would say that as a major gloss, the two frameworks of history that are kind of quite waves that are quite influential in the field are the biographical history of medicine. So, in many ways, the American Association for the History of Medicine was founded 100 years ago. We just celebrated our 100-year anniversary last year. And the histories that were told in the beginning were great doctor histories. And so that's a biography of William Osler. You all have probably heard of Oslerian medicine. He is considered a founding father of the medical humanities. And a lot of these early histories were histories of scientific medical progress, told through the perspective of the great men, almost all white men, right, who were the ones who were driving the so-called progress. You can also get sort of the flip side of that. And Jacqueline Duffin, who was an MD PhD in Canada for a very long time, would open her class to medical students by having great figures in the history of medicine and talking about, were they a hero or were they a villain? Because many of the people who were once put on pedestals, and many years later, we are able to view them from a different light. But either way, we're looking at sort of the psyche, the lives of quote unquote great historical figures. And when you think about archiving, most of the ways that these histories are produced are because the actors, the figures, the main characters, left behind archives because they expected to be added to the pantheon of great doctors after their death. So that was up until about the 1960s, although there were exceptions. The mainstream of the history of medicine was this sort of medicine, Whiggish history, scientific progress, great men. Okay, next slide. What came next was the social history of medicine. And so that was history from the patient's perspective. In the 1960s, we saw, and 70s, we saw, sort of the trinity of race, class, and gender histories emerge. This kind of the history, the equivalent in history of medicine was history, the patient's perspective, history from the bottom up. There are two sort of critical essays to that effect. One was by David Rosner and Susan Reverby, Beyond the Great Doctors, arguing for a social history of medicine. Um, Another one is Roy Porter, The Patient's View, doing medical history from below. But it was looking at the perspective of the history of medicine from the patients, not from the doctors. And the way that this kind of history gets done is often reading official institutional archives, kind of against the grain, right? From the perspective, patient records from the perspective of the people that were written about, instead of from the doctor's perspective, assembling archives of everyday people. What was the life like? What was a day in the life like of a person who did not wake up spending every day thinking that they were a world historical individual, and often and maybe gathering oral histories, right, in order to correct or illuminate the historical record. So there's an acknowledgement doing this kind of history that the great men history, the history of the powerful, is incomplete. And a lot of what social historians are trying to do is to go about troubling that record, correcting that record, filling that record out with more diverse perspectives. So that's social history of medicine. Medical humanities as kind of a field and being institutionalized in medical schools also happens around this time. Also around the same time as bioethics starts gaining a foothold in health professional training. Okay, so reparatory history. Next slide. How is that different? So reparatory history, and there are people who have been doing work in this vein, of course, all along. And as I said, this is a major gloss, but I want to point everyone to this book that came out a couple of years ago. The Do Less Harm book was a collective effort. A bunch of us, we were convened by Courtney Thompson and Kylie Smith, who met each other online when their books came out in, I think, 2020. And they met each other online in the American Association of the History of Medicine, and ethical questions came up in talking about their first books. And they realized, rightly, that historians of medicine had perhaps been late to think critically and self-reflexively about their own methods, or about how ethics applies to the teaching and doing of history. And so they convened a working group through the Consortium for the History of Science, Technology, and Medicine. And some of us were around from the very beginning. Other people came on later, but it was essentially a synchronous symposium started during COVID that then carried on afterwards, where we were just asking ethical questions of our own work. And what came out of that consortium group, working group symposium was a series of essays, their first person essays. The book is not a textbook. It's short, sort of inquiry-based reflections on the process and work of doing history. So who you are, thinking about your positionality as a historian, research, what does it mean to do research, teaching, writing, public scholarship. All of this was very much sort of herded by Courtney and Kylie, but it was a very collective enterprise, and I found it very generative, and it was certainly a very different way of doing history than I had been trained to do, which is kind of by two wonderful. I had a very paternalistic, graduate training, right? And while I was involved in scholarly associations and conferences, certainly it wasn't. It didn't have this collective feel It was a new experience kind of generationally for me. And I will say, if you pick up the book, it's got, in addition to the essays, a really lovely bibliography of things to read, a really lovely appendix of questions to ask yourself and ask your colleagues. It's not a textbook. It's not a cookbook. The essays that are in it we don't even always agree. But the way the book is framed and what we as authors signed on to was with the notion that we were endorsing a kind of what we called a harm reduction approach to doing health history. And some of the things that we could agree on, or that we do agree on in these essays, is that history is a process of inquiry rather than a set of facts and timelines. And so the book models that process in the sense that we're each of us asking questions, grappling with questions, taking up questions that each other asked, and not producing a sort of one definitive, correct historical account. It acknowledges that producing historical scholarship always has the potential to perpetuate harm. And so I think particularly when you think about excavating history, writing history, engaging with histories that involve very real injustices, harms, and trauma, like working with that material, working with those people if they're living, even if they're dead, dredging that stuff up. All of it is that that's not a neutral process, right? And we as historians, we do it to for the benefit of our own careers, right? And I think we were sort of, well, it's part and parcel of, say, being an anthropologist that you consider, your self-reflexivity and accountability. I think as historians, we often like to hold ourselves to some kind of objective standard, or as though we're above that. And so what we all talk about in this collection is that we're not. And there are going to be ways that we can anticipate the harms that are caused through the scholarship we produce and try to mitigate them. And then there are going to be harms which may come up in the course of doing scholarship, for which we need to understand from the outset that we are accountable for them and to hold ourselves and each other accountable. This particular group, right, sort of came up, in the midst of Black Lives Matter summer, COVID-19, all of those kinds of things. But and a lot of our participants were, brought different sources of inspiration into their own health history scholarship, including, disability history, histories of medical racism, reparatory history itself. I didn't write that essay. Kylie Smith wrote that essay, and it's a lovely essay on reparatory history. And talking about how the reparatory history and the history of medicine owes much to the discussions about histories and legacy of enslavement and medical racism. But it's not just that. And so we don't want it to get as like that it's only that this is, only having to do with medical racism. It also was inspired by mad studies and things like that. So, and then I would just say, like, reparatory history is not the same thing as journalism or law, right? I am the oldest daughter of a journalist, a recently retired journalist and editor for 30 years. And that's what they do. They expose things. They raise public awareness. They write the first draft of history, but they're not historians. And so, and then lawyers. I mean, so there is a chapter in this book where we talk about working as an expert witness, of which I know several expert witnesses who helped the OIDA documents come into being, right? But we're not lawyers. And so thinking about that, the archives that we work with often as historians with this kind of sensibility come from the work of people who have agendas, right? And even if we agree with their agendas and we think they're good agendas, right, that we need to be able to hold ourselves back from them in some way and think about how we're writing for a kind of longer time scale and for a different purpose. Okay. Then I just have a couple more just points to make. If next slide. And that so if we think about OIDA as a repertory history, right, which I do believe that the archive itself was founded around the same time, around 2020, 2021. Okay, next slide. I am it's newer. This archive is maybe less than 5 years old. The Tobacco Legacy Documents archive has been tremendously generative for historians of health and medicine. And oh, sorry, there's a little that pushing cool is on there twice, but the sort of canonical book that was written from that archive was Alan Brandt's Cigarette Century, which traces the rise and fall of the cigarettes, largely written. He was an expert witness against cigarette companies and wrote that book from those documents, many of which are in the Tobacco Legacy Documents archive. It is a very top down, sweeping rise and fall of big corporations kind of history. Sarah Milov's book, The Cigarette, was also used those documents extensively, and she writes a much more grassroots history, a much more local history of how political change and activism occurs at the local level, much more bottom up policy history rather than top down. And of course, Keith Wailu's more recent Pushing Cool uses those documents and really zooms in on how tobacco was marketed to Black communities. And so the racial disparities of commercial determinants of health. Okay, so next slide. So we don't have those books yet, I don't think, from the OIDA archive, right? So I think the archive is still in progress. The historians are still writing the books. I think the focus has been on documents that are produced via litigation against the pharmaceutical companies, where pharmaceutical companies executives, much like tobacco industry executives, just say horrible things in print. Toggling around the website, there's been some fantastic interdisciplinary scholarship and teaching resources on the commercial determinants of health, which is a new field, which is a newer field of public health research following on the social determinants of health that we didn't talk about in quite those terms when I got my public health degree a little over a decade ago. But the histories are very much still being written. And so I think we can look at the histories, those three that I mentioned from the tobacco documents, and think, well, are there equivalent histories to be written from the OIDA documents? Or are there opportunities to shape the archive in ways that might allow for different kinds of histories? Okay, next slide. Okay, so future directions, next slide. And so I will just leave with some questions that we can maybe pick up on for discussion. So this first question came from David Hertzberg at a panel that he moderated on archiving. And I thought it was, it was like such a weird question. I couldn't answer it at the time, but I wanted to pose it to you all and see if maybe we could answer it together. But when you think about working with archives, like a lot of the time, if you have the opportunity to go in and hold the folder in your hand and go from beginning and some of them tell a story, right? And I feel like the Tobacco Legacy documents, they tell Alan Brandt's cigarettes rise and fall, or they did up until it was written, you know? They tell a story or they have a voice. And so thinking about archives in that way, like, I don't know, does OIDA sound like the Tobacco Legacy documents? if the archive itself were an actor, because it is in a way, right? Like what materials are available for us all to look on and work with is going to influence what we think and the stories we tell. What would it say? What would it sound like? How are people with different lived experiences interacting with the archive? There were the U.S. Public Health Service syphilis study at Tuskegee. There were just a ton of recently issued documents released and digitized and put online from that archival project. I teach a graduate seminar in the history of medicine among African Americans. We were talking about it and the potential harms of that in the sense of like some of those documents they're horrible, like the racism, just the explicit racism is really quite shocking. And some of the students in the class were like, I don't know, like, you put those online and think that people will read it and recoil, right? But people read it and think that's great, you know? So how are people with different lived experiences interacting with the archive and with the documents that are available? What perspectives are present? What perspectives are missing? I know that it's one of OIDA's objectives to get more oral histories, perspectives of people with lived experience. And then, yeah, what are the benefits and harms of the way we're doing this? Archiving and remembering the opioid crisis, right? Which is has a long history, and has and has a future, right? So that's those are my slides, and if I have inspired anybody to pick up some further reading, and you know, or go to an archive, I'll consider my job done. But that's okay. Thank you.
Thank you
Um,
so much, Claire, for the wonderful presentation. It was very interesting and insightful. I would like to switch over now to Tracie Gardner. Tracie has worked for more than 3 decades in the public health, public policy, and not-for-profit fields, with a focus on substance use and the impact of the war on drugs and incarceration on Black communities in the United States. Ms. Gardner is a nationally recognized expert on health and race inequities. As a highly requested speaker on these issues, she is often quoted in the media and contributes to various research and journal articles on institutional racism's impact on the health and criminal legal systems. She is currently the executive director of the National Black Harm Reduction Network, a newly launched advocacy and technical assistance organization that is dedicated to advancing harm reduction principles that optimize health and wellness for Black people who are disproportionately harmed by public health initiatives, the criminal legal system, and drug policies. In May 2024, New York Attorney General Letitia James appointed Ms. Gardner to the state's Opioid Settlement Fund Advisory Board, which provides recommendations for how New York's opioid settlement funds should be used in communities across the state. So with that, I would like to turn it over to Tracie.
Thank you, Tanner. And thank you to the Opioid Archives for inviting me to speak. I probably should update my bio to note that I have served my time on the New York State Opioid Settlement Advisory Board and working with the Attorney General to appoint my replacement. And so I really appreciated Dr. Clark and the broader context of medical history and the, during a time, quite frankly, where it feels like there's a deep intentionality of erasing history. It is, I'm grateful for archives that are about preserving the history of different both movements and particularly the health history is critical to be protected, because if we don't understand it, especially here in this country, we're not going to understand how to even improve our health systems if we don't understand the history upon which it's built. And this is the 250th year of this country's existence. And it is literally intertwined with the build out of our healthcare system. And by that, Black Americans have always been the canary in the coal mine for both health, emerging health threats, and the impacts when there is, when you neglect or don't take a very intentional approach to addressing the unfolding health issues. So let me get started. I'm going to try not to editorialize too much, but I don't know if I can help it. Okay. So again, National Black Harm Reduction Network, it's a new technical assistance and advocacy organization. But the concept of Black harm reduction is not new. And Cassandra Frederick, who's the executive director of Drug Policy Alliance, when we were having a conversation about the need for a National Black Harm Reduction Network, talked about the fact that we need to reduce the harms of being Black in America. And maybe at the time, this was prior to George Floyd, it sounded hyperbolic to some people, but I think given recent events, it's very easy to understand that this is not just focused on the disproportionate impact of the overdose epidemic on Black communities in this country, the criminalization that's inherent in drug policy. And so I believe we are currently the only national Black organization directly addressing drug policy's impact on Black communities. So starting from the very important piece, that the opioid epidemic was not the beginning of drug-related harm. And it really feels like it needs to be said. And I know a lot of people who are watching and folks who are on the panel, in many ways, we're preaching to the converted, right? We don't have to really convince ourselves. We've seen this unfold and know that it's very much about people who are valued and people who are not. But this is also not our first opioid epidemic. And had we addressed our first or previous opioid epidemic, the impact of the current opioid epidemic, I argue, would not be as dire. And so Dr. Clark talked obviously about the embedded history of the have and the have-nots, or the people we value and the people we don't. And the criminalization and exploitation and experimentation on Black and brown bodies is as American as apple pie. It isn't an accident or some glitch that there is a disproportionate impact of overdose mortality on Black Americans and Native Indigenous people, two groups in particular who have been the subject of United States policies of criminalization and displacement, and I would argue terror. And so again, 250 years ago is not that long ago in the kind of human span of time in this country and in our existence as a species. We have, for a variety of reasons, maybe to support social coherence, we have always gone after sex and drugs, these things that people do and have always partaken of. We have figured out ways to legislate it, and we figured out ways to surveil it and control it and contain it, and yet it continues to be the landscape upon which we do some of our worst to each other as a society. So we talk about the history, and we talk about, again, the use of drugs and the criminalization of drugs and what that means. And everybody knows about the Ehrlichman remark during the Nixon era of intentionally focusing on Black people and hippies. But it also goes back as far as cannabis and this idea of the people who are, we don't value. Negroes, Hispanics, Filipinos, and entertainers, right? And anything that's outside of the Judeo-Christian framework of who we're supposed to be then gets the long arm of the government in punishment and criminalization. And that's the father, Harry Anslinger, of a lot of the coercive drug policies that we still deal with today.
Tracie, I'm sorry
So
to interrupt,
again,
but are we supposed to be seeing your slides right now?
yes.
Okay. We weren't sure if you were still introducing things, but I had a couple questions.
Hold on.
Okay.
All right. I did not share the screen. That's why. Can you see that?
It's loading right
Yeah.
now. We're seeing PowerPoint. Yep. And then if you start the slideshow, then we'll have the full view.
You see anything?
We're seeing your PowerPoint application, but your slides are kind of small because it's just part of the window. There we go. Perfect. Thank you.
Okay. I'm not going to start from the beginning. You're just going to have to take my word for it when I was talking. But I was just finishing up with Harry Anslinger, who was the godfather of punitive drug policy. I was right here at this, again, the short period of time in which we've been able to promulgate a lot of policy and approaches that have been singular in their focus on Black people. And so, again, from our time in this country, you see the green section we're in is fairly recent. And so, there's a lot of history behind us to either address, be aware of, and try to undo the harmful parts of it. So we talk about harm reduction, and I have to talk about harm reduction, ending up as the second, in the second sentence of a federal letter from the Federal Substance Abuse and Mental Health Services Administration of this administration was disturbing, to say the least. But we're incorporated, this is our name, we're National Black Harm Reduction Network, and we're not going to change it, or we don't have the luxury of calling it something else. We talk about harm reduction because it's a way to acknowledge that it was a strategy that came out of people who weren't valued needing to protect themselves. So Black and Latino drug users who were protecting themselves from HIV and other bloodborne diseases, when the institutions of care that should have mattered or should have cared about this as a public health threat to everyone, instead blamed the people at risk for this illness and drove them even further away from the systems of health and care. And so these principles of harm reduction that embrace both self-protection, that minimize damage, we talk about requiring abstinence as antithetical to harm reduction, but it's more about imposing behavioral standards and really ignoring what people-centered means. So harm reduction isn't just about bringing people or meeting them where they're at and leaving them there. It's about embracing their fullness and humanity. And there's not very much in our history that shows that that is our default setting. It's quite the opposite. And I've always said harm reduction is love. Either you want a person to live or not, and just that's it. That's binary. You want a person alive or you want them dead. And I think, yeah, we'll not editorialize. So I like to talk about this round of the overdose epidemic and the narrative unfolding from the pharmaceutical companies were dishonest and duplicitous in their identifying these painkillers as non-addictive. The subtext of that, of course, is you won't become addicted like those people. And those people are the people who Harry Aslinger identified as less than desirable and a threat to societal structure. And so in thinking about that, we have not built preventative strategies. We focus as a country, our healthcare system and our other social services focuses on addressing emergencies. And I think COVID showed us that our safety net that we think people are falling into when we don't take care of them is actually so fragile. And once the face-to-face interactions disappeared because of COVID, we saw, and I think we're continuing to see, the impact of that disconnect, and that we are social beings, and that this idea of active addiction, the opposite of it is connection, really was brought home during COVID. So, and we also have to talk about, especially now with the commercialization of and the kind of capitalism meets addiction treatment systems, and the fact that there are these large corporate entities that are making investments in addiction treatment centers and recovery centers. And a lot of it has to do with the narrative that has unfolded over time that people who use drugs will always be drug users, will always be addicts, will never get better. But we, in fact, do not have a system that is interested in getting people better. And I would say it actually thrives on people being just well enough to have to come back. And that's a powerful business model. It means that you will stay in business. There are very good people and organizations working with people who have struggled with their drug use or who are in chaotic drug use. But we've built systems that don't ask why people use drugs. We distill their drug use to their only and most important failure as a human being. And we have built a whole system around addressing that one issue in someone's life. So as we continue on with technology addressing our healthcare structure and emergency, we see that epidemics come down and the medical solutions rise up, and they're accessed by the wealthy. And I'm going to talk a little later about HIV and the work that I was able to do during the early HIV days that really mirrors so much of what is going on and continues to happen in the aftermath of the overdose epidemic, and also the attempt to redress the damage through the opioid settlement funds. So I talk about HIV because this is how I grew up. This was my social justice lens. I came to New York in 1989 because I'd lost my childhood friend to AIDS in 1985. And even then, I could hear the ideas about my friend who was gay, but he also had girlfriends, and the idea of sex, and then the hushed terms about, oh, and I think he was using drugs too, really brought together that these villainized human behaviors were where the primary response to it was just say no or be abstinent or be pure, ignored the public health implications of societal interaction, sexually transmitted diseases, living in close quarters, the trauma that using drugs often helps to mitigate. So again, in 1996, once we figured out that protease inhibitors were the intervention that people were hoping for, it wasn't cure, but it was very much a turning point in addressing HIV and AIDS. And for you to benefit from the discovery, you had to be in good care. And so HIV in the 90s helped build a giant infrastructure of care in many parts of the country. And while HIV has not been completely mitigated, we are closer to a cure or a vaccine than I ever thought I'd see. I didn't think I'd be alive to see long-acting injectables that people can use to keep from contracting HIV. I just didn't think I'd be alive to see it. That was rapid research, rapid development, but that was also about who HIV was perceived to hit first. And that was white gay men. And I worked at Gay Men's Health Crisis in the early 90s, and it was a advocacy powerhouse. And I learned a great deal from my time there. And I have many colleagues, I'm grateful, who are still alive from that time, where I learned what it means to, when the mothers of these gay men saw their children in the hospitals and wards where Black and brown people were generally relegated to, they said, absolutely not. And these became the white moms who were talking to the congressmen and the senators. And that's how we got Ryan White Care Act. And we got Elton John embracing a young white kid. And we got Michael Jackson befriending him, right? Like, so a champion in celebrities, political leadership championing this, and then also the element of compassion. And this is someone, an innocent who contracted it through blood transfusion, that we can organize ourselves around. So National Black Harm Reduction Network, our Gen Zs have us calling it NBURN, and I like it. We came together around the time that the narrative about the impact of the overdose epidemic was changing, and this idea of the new face of addiction. And the fact that harm reduction was pioneered in the days of HIV and was scoffed at by many of my mentors, Black and brown mentors, who told me this is just a way for white folks to be able to use drugs and not have the same impacts that hit Black and brown people. And we do know from decades of data that there's more drug use among white communities than there is among Black communities, but the narrative has not served that reality at all. So understanding that drug policy is about race, which then means healthcare is about race. And also, I like to talk about the mental hygiene system is about race and the people we like, or the people we cherish and the people we don't. So, you know, again, we saw the double standard happening as this unfolded in how we were addressing opioids versus crack. And yes, cocaine and opiates are two different substances and they have different impacts on people's bodies, but it leads one to question, after a while, the drug courts were developing, and there was even a highly touted opioid court that was launched in Buffalo, New York, which makes you wonder, were the rest of the courts crack courts? I mean, the issue of singling our whole focus on opioids has left us kind of ass out now that stimulants don't have the same FDA approved medications with which to address the the nature of opioid use disorder, and that it's only recently that we are even caring that the detoxification, when people are denied their opiate medication, that they suffer greatly. Well, they've always suffered, right? But it wasn't until people that we care about started experiencing that, the mothers who saw their children writhing on the floor or on the floor of a jailhouse, vomiting and shitting on themselves, that policy started moving. We talk a lot about, again, this is where we talk about systems intertwining. And so the drug system, the drug addiction system, or the addiction treatment system intertwining with the criminal justice system, those are peanut butter and jelly. And then you put in child protective services, and you have this debate around the innocent and the guilty. And now we have a state such that overdose and suicide are the drivers of Black maternal mortality. And that was it's just as true now as it was back in the late 80s, when people who were delivering their babies in hospitals were threatened with having their children taken from them. And they were, in fact, 40% of child removal is usually newborns. So we criminalize substance use and mental health disorders, or I call them health issues of the mind. We have always had a separation of health issues of the mind, that's the mental hygiene system, the dirty mind, and either you are affected mentally organically and innocently, like ADHD or autism or epilepsy, or it's self-induced. So substance use, heroin, crack, and it's the same brain. And we've at least come up with a term to acknowledge that these things can be happening in the same brain, often bouncing off of one another, but we still have policy and systems that treat our minds as though they're good or bad. So again, we have always played fast and loose with our hypocrisies about who can use drugs and who can't, and what we think drugs should be used for and what they shouldn't. We talk about overdose prevention centers, and we don't like the idea of people being able to use on the premises. And we have federal crack house statutes that keep overdose prevention centers from existing, and yet bars continue unabated with the substance freely available, monitored, regulated, overseen. And if the supply is poisoned, we know about it right away and we take action right away. And so when we have seen often that when you prohibit, you create a whole new demand. And that's what we saw in the narrative, the prescription pills that then went to heroin, that then created a vulnerability to the entrance of fentanyl, which was killing older Black and Latino men in parts of New York where I live very early on in 2012, 2013. But until it hit Long Island and Staten Island, we didn't care. So either we go from no regulation to some regulation to prohibition. And so again, keeping in mind, look at that, Bayer Pharmaceutical helping us with heroin. I mean, heroin assisted treatment is effective and it's used in Europe. And our flip outs around methadone, which I was able to get at CVS for my mother when she was dying of cancer, but the minute she would need it to relieve her symptoms as an opioid use disorder, it comes under Byzantine, impossible barriers and regulations, which makes you kind of think that they don't really want to use it to get people well. And quite frankly, methadone was not formulated to get people well. It was formulated to control behavior. It's a criminal justice tool. So it's great that it's the gold standard now, but we must keep in our history where things come from. Their beginnings matter. So again, cocaine tooth drop. Again, back in the day, we knew what worked, and then depending on what the social scene was at the time, it's either a societal good or it's a societal bad. And that has everything to do with the politics and the politics of people we value and people we don't. So briefly, because I get to talk a lot about opioid settlement funds, not only because I was on the settlement board for New York, but I worked for 10 years as the settlement funds were being formulated around the approved uses. So I'm not a lawyer. I love them. I love to boss them around when I can. But tobacco settlement should have told us something about the fact that these remediations were not going to get to where they were needed the most. And when has settlements ever been not directed to the people harmed? So there we go. These were developed by lawyers. They're impossibly dense and I think purposefully opaque so that we can't identify the funding to ensure that it goes to where it needs to go. And then to put it into government, which I had a little bit of experience of working inside of government, and it was confirmed for me that government does not know what to do unless we tell them what to do. So the money will not flow naturally to where it's needed most. It will flow to where the resources are the most bountiful to receive them. And that is big hospital systems, that is law enforcement and other criminal justice entities, because these are the pathways for funding that we developed, not just since the war on drugs, but since always. And I did a Substack about new wine into old wineskins, because we can't expect that settlement dollars will go to where they're needed most. And that's why Black and Brown people are still dying, even as the numbers are diminishing in terms of overdose mortality. So what should justice look like? You know, the litigation settlements, corporate accountability, public statement, funding announcements by attorneys general. And that is in the face of the housing instability, underfunded harm reduction programs under attack by a federal administration, workforce shortages, and lots of unaddressed community grief and trauma. I'm going to end with our ethos is that Black harm reduction, in terms of addressing the policies that are intertwined to create a unique harm to Black communities in this country, is not sufficient. We are moving toward harm elimination, and Black recovery relies on transformational change. So if we acknowledge that reducing the harms of being Black in this country, if we acknowledge that when Black people are healthy, all of us will be healthy, all boats rise, and that opioid settlement funds could help dismantle and replace, instead of tweaking the systems that we currently have, could really build lasting elements to support community health and wellness. Thank you.
Thank you so much, Tracie. That was an excellent presentation, very informative. Now I'd like to hand things over to Coryn Mayer. She is a registered nurse at an FQHC site, certified in addictions and HIV/AIDS nursing. She has clinical experience developing and implementing individualized opioid use disorder induction, tapering, and monitoring protocols for fentanyl use disorder and chronic pain management among chronic disease patients. A specialist in drug policy implementation, Coryn serves as Director of Policy at United Against Fentanyl, a 501(c)(3) nonprofit organization where she provides policy research and legislative analysis to inform bipartisan state and federal advocacy efforts in response to the overdose and poisoning crisis. Her scholarship has been published in the Journal of the Association of Nurses and AIDS Care, the Journal of Psychoactive Drugs, the O'Neill Institute for National and Global Health Law, and the Opioid Policy Institute. And with that, I'll turn it over to you.
Thank you so much for having me. Let me share my slides. Okay, so my name is Coryn Mayer, and I am presenting on cephalon's influence of actique fentanyl citrate prescribing for sickle cell anemia vaso-occlusive pain. So for some disclosure, so I completed this research independently. I am employed by Whitman-Walker Health as a registered nurse. I do not represent Whitman-Walker Health. I also serve as policy director for 501(c)(3) United Against Fentanyl. I don't represent United Against Fentanyl, and I receive no funding to complete this research. So there is a quote that I would like to share, and it's you never want to be the first to use an you never want to be the first to use a new medication, and you never want to be the last to use an old medication. So when I was a graduate student in the Addiction Policy and Practice program at Georgetown University, I also TA'd for a medical ethics professor, Dr. Jeffrey Spike. And this is a quote that really stuck with me. And it's a quote that I think about when I work with my patients. It's a quote that I think about and I really integrate into my practice and will continue to integrate with my practice as I progress in my career as a registered nurse. And in discussing the opioid epidemic and new medications that are coming out of the pipeline, it's really important I think it's really important to integrate this quote and how we evaluate evidence before we implement new medications into a clinical environment. So just for the agenda, so I'm going to present some background information, some methods, my data sources, which came from the archive, and then the findings, and then I'll conclude with discussion, limitation, and future research. So first off, what is sickle cell anemia? So sickle cell anemia is an autosomal recessive disorder that affects your hemoglobin. It is a genetic disorder, and it disproportionately affects people who are African American or non-Hispanic, Black. And so what is hemoglobin? So hemoglobin is a protein in our red blood cells. It carries oxygen we breathe in, carries oxygen to our tissues when we breathe out carbon dioxide. And so this is really important because when hemoglobin S, which is the abnormal hemoglobin type in sickle cell anemia, when it polymerases, when it's deoxygenated, it sickles. And you can see this on the image to the right, and it kind of looks like a clog, and that's called vaso-occlusion, and that can be really painful. So this is a very pathological type of pain, a nociceptive type of pain. And so the clinical guidelines from the National Heart, Lung, and Blood Institute, once you're in this significant pain, it's called a sickle cell crisis. It's severe enough that you need to go to the emergency room. It needs to be addressed within 30 minutes of arrival. So what are opioids? And so I'm not going to get too far into this, but it's important to acknowledge that opioids affect our entire organ systems. And, it's not only our brain, but it's also our gut. And so we see things like chronic constipation as well. And so this is important to really to acknowledge when in discussing the opioid archive literature, and especially what we know today. And I'll discuss later, but these label changes actually didn't occur until almost 20 years. Of all these side effects, didn't almost change until 20 years after these medications went out on the market. So what are some statistics of sickle cell anemia and opioid overdose? And so there was a study that was done in 2005, and 0.3% of overdoses had a co-diagnosis of sickle cell anemia. And what's important about this study is the risk factors for overdose were the same as if you did not have sickle cell anemia. So that's poverty, racism, and age. And the amount of people who have sickle cell anemia and have opioid misuse, that percentage is no higher than the national average of chronic pain sufferers. And so this is really important to just acknowledge that all pain should be treated and addressed adequately, and we should absolutely avoid any type of stigma in approaching any type of clinical decision making. So what is my research question? Why am I here? I don't have a PhD. I'm just a massive nerd. And Kevin and Amanda invited me to go play in a library, and I said, absolutely. And so, well, why am I here? So my research question was, how did the opioid industry fold into the sickle cell anemia pain management narrative, and how did the opioid industry influence opioid prescribing for vaso-occlusive crisis among patients with sickle cell anemia, and what was the impact? And integrating this into my colleagues' presentations, all of this is put into context of opioid access and the history of opioid access, particularly among patients who are Black or African American, and their access to pain management. So how did I do this? So I did a fancy methods, and I did a fancy type of methods, and I did a hermeneutic document analysis. And what does this mean? So, this is not a dissertation, so I'm not going to go into it too much into depth, but essentially I had many, many search terms, and you can see here that they produce thousands and thousands of documents. And I went through every search, I went through about 5 pages of documents. If I saw something that was interesting, I then looked through executive summaries, or if I was trying to find a particular answer to any of my questions, I would spend more time on that document. And so ultimately, I selected 44 documents for further evaluation. And I selected a total of 18 that I read in more depth. The documents I will discuss today. I'll discuss documents that are more related to more recent opioid OIDA publications that have just been published. But of all of these 18 documents, I essentially plopped them into different types of themes, and this is called a thematic analysis. And so I, looked at the meaning of these documents. I tried to contextualize them within history, and then triangulate other sources. And those other sources would be deposition documents, or Attorney General immediate release reports. And so something that was interesting. So when I came up with this research topic, I didn't really know what I wanted to research. I just started research. I knew I wanted to do something with sickle cell anemia. I had a handful of patients who had sickle cell anemia when I worked in the inpatient setting. So I had many patients who were on long-term opioid treatments and had very pathological type of chronic pain. And sickle cell anemia specifically came up with the company named Cephalon, and particular for this product called Actique, which is a transmucosal fentanyl. And what that is, I think of it personally as a fentanyl lollipop. And it was approved in 1998 for cancer-related breakthrough pain. And it was approved by the FDA, and the company that developed it was named Anesta. And Cephalon acquires Anesta in 2000. And so what we're really looking at is what happened in this decade between when the FDA updated their risk evaluation mitigation strategy. So the first performance review was published in 2002. And so this looked at 2001 data. And so at this point in time, the brand manager, the director of the brand Actique, his name was Andrew Pfeiffer. So he publishes this document internally with his team. And what we're seeing here is that there is a significant amount of prescription growth, and there's a significant amount of sales growth. So to him, this is a very marketable, a very profitable product. We're also seeing that he's wanting to step into the non-malignant patients, so non-cancer patients, get more outside of off-label prescribing. And this is really important because if we look back at how Anesta got Actique FDA approved, they shook hands with the FDA. They said they agreed to specific terms that they needed to that requirements that they needed to abide by from the FDA, and that included things like getting marketing materials approved, not tracking any type of off-label prescribing, and very strict regulations. And obviously, they did not adhere to that regulations, which is evidenced by the settlements. So in So what are the objectives? So they really wanted to capitalize on the mechanism of action of fentanyl. And what is that? So that is a rapid onset type medication. And so they put 76% of their marketing budget into off-label prescriptions. And so they did this through door-to-door calling. They did this through medical journal advertisements. And so this was one of their slogans, Actique on Call. And we see here that sickle cell anemia crisis is specifically named as a target population. And so how did they do this? So, I mean, I think of this. So in 2004, I was in kindergarten. How did they convince prescribers to prescribe a fentanyl medication for breakthrough pain? In the non-cancer population, how they do this. And so they did this by redefining what breakthrough pain was. And so in medical literature, there is really no clear, universally accepted definition of breakthrough pain. And they exploited this. So we see this graph here, which was presented in many of the sales training. And what we're seeing here, this bell curve represents the current breakthrough medication. And then what we see, these spikes. And so those spikes, those are pain episodes. And so what they're saying is the current breakthrough medication is not fast acting enough to treat a breakthrough pain episode. And they're pushing that the Actique product, the fentanyl product, is the best product that we have to treat breakthrough pain. And there was no evidence that supported this this graph here. There was no evidence cited. It's very much branded by Cephalon. So they decided to create a target list. So by 2004, they had a pretty significant target list. And so when I think of, patients with sickle cell anemia, where do they access their pain medications? And, it really depends. It depends on a provider's experience level, their comfort in prescribing medications, possibly a very well-seasoned family practice provider, possibly more likely within hematology or pain management. And so we look here, we see that hematology and family practice have significantly more prescribers that prescribe this medication than pain management. And so this is from the same document, and this looks at some prescribing productivity. This was just a snapshot. I do wish that it was an Excel file to go through, but we do see the small snapshot, and we see that 22% of Actique prescriptions were prescribed in 2003 were prescribed for headaches, 65% were prescribed for generalized pain, and only 13% were prescribed for malignancies. And so what I found interesting in this, not only that breakdown, but was the amount of units per prescription. And so let's just go into that other category. Let's be generous and go into the other category. And so in 2003, there was 56 units per prescription. And so for the label, I read the Actique label. It's not a product I'm familiar with at all. I don't work in anesthesiology, but it was very interesting to read this. It's the max dose that you can have is you can have one lozenge every 6 hours, but 56 lozenges, that would be 15 days of breakthrough pain with, every 6 hours, breakthrough pain every 4 hours. So at that point, as a provider, I'm thinking, okay, like our pain management is just not working at this point. We need to completely reevaluate our approach. So let's loop this back to sickle cell anemia. And so in 2002, there was a provider who reached out and said, hey, I really want there to be a clinical trial on Actique for the use of sickle cell anemia vaso-occlusive breakthrough pain. And so this went up the chain and it went all the way up to Andrew Pfeiffer. And essentially the answer was no. We do not have the funds to do this. And this was also validated. The lack of research for safety and efficacy research was validated through his 2018 deposition. And so, but this really presents this ethical concern of that cephalon was benefiting significantly from off-label use without any type of research supporting the safety and efficacy because they were advertising for off-label. And so what else did they do? So in this the internal sales team, they would share case reports of the use of Actique for sickle cell anemia, for sickle cell anemia, vaso-occlusive pain. And what's interesting about this particular study is the sample size n equals 3. It's also a multimodal pain management approach. So just from, as, a healthcare provider reading this is not a strong source in pushing in, using a medication or integrating that into your practice. But it's what the company did anyway. Oh, right. So something I found very interesting was when I was looking in the OIDA archive was that pediatrics kept popping up. And I thought, this was very interesting because of the mechanism, the route of administration of this product. It's a lollipop. So I found that to be very interesting, very concerning. But let's talk about this trial. So Cephalon wanted to tap into peds. Actique was only approved for adults with cancer. They wanted to tap into the pediatric population. When they opened a clinical trial for kids with cancer who had breakthrough pain, they did not have enough children to enter the trial. So they opened the trial up to patients who had sickle cell anemia related breakthrough pain, as well as kids who had severe burns. And so these methods were not published. I tried to look at them publicly, then I couldn't find them. And then I tried to look at them within the archive, and I was not able to find the protocol for this. But at this point, as someone who has worked in controlled substance trials and who has, worked with patients who have have been on narcotic medications. At this point in these trials, what my assumption is that at this point you're really you're comparing route of administration. So that would be something like a patch versus a lollipop, and essentially millimeter equivalents of morphine. So from, jumping to the top of my brain, I'm posing a little bit of judgment here, but this is clearly not safe. And there were no publicly available results published. But there was one small report that was private, that was saved privately within Cephalon's records that I did find through the OIDA documents. And what it did show was that there was no statistically significant differences observed in whatever their active placebo was. There was, and as well as the FDA then, saw these results and the data, and they essentially said, no, this is not FDA approved for pediatric patients. And they do cite that there has been serious adverse effects with off-label use, as well as use in non-opioid tolerant patients, improper dosing, which led to their denial of this application. So something I think is interesting is, what did this sales training look like? How were these sales reps educated on opioid medications? And so there were two things that really popped out to me, and one was the complete minimization of pharmacological risk, as well as any type of avoidance of risk communication. And so minimization of pharmacological risk, essentially these sales reps were taught that the opioid medication is inherently safe. That's what they pushed to prescribing providers, and that the regulatory framework was safe enough to prescribe this medication, which obviously we know Cephalon had very malicious intent because they did not follow the FDA regulations. And so they emphasize the regulatory controls to convince providers that this medication is safe. And they also deferred any type of addiction potential on the individual rather than the engineering of the medication. And so when any type of provider really shared any type of concerns about this medication, these sales reps are really taught that they need to, and I quote, like, de-chill the provider. And in this particular training, they had to drag a ray of sunshine on the provider to de-chill them. And that really, downplays the very real harms about the pharmacology of any type of medication. And they tried to exploit providers' fear of not managing any type of symptoms for their patients. And so this is another file that I did find was interesting. And this is an Excel sheet that has thousands of sales calls. And you can see that you can see, who called them. You can also see where they called, and then the specialty. And you can also look through the provider's concerns of these calls. Some of these concerns mainly were reimbursement issues when a medication isn't covered by, when a medication isn't, especially new medications are not researched for the clinical indication that they've been approved for. It's very rare for them to be covered by insurance. And there's also fears that providers showed, including the titration period and different type of monitoring. So by 2006, Actique and Cephalon, they've really identified ways to band-aid any type of concerns. They don't address them. They don't improve the safety and monitoring. They don't fix all the damage they've done. They just decide that they are going to strategize on how they can continue making more money. And so one of those things was the continuing of the breakthrough pain awareness campaign, as well as they decided to create a reimbursement program called Covens to help patients pay for the medication. So now we are in 2008, and we see that there's a lawsuit for $425 million for off-label drug marketing, and these are for violations of the Food, Drug, and Cosmetic Act, as well as False Claims Act. And so a significant portion of this money was put back into Medicaid budget, the Medicaid budget, and we don't really know how much of this money has been spent, and where it went. And you do see here that sickle cell pain crisis is specifically identified. So there is a story here in how Cephalon tried to target patients with sickle cell anemia related pain. So now in the discussion, so to discuss this in context of other OIDA documents, so we do see that the logo, the Actique on Call, the definition, the redefining of breakthrough pain, it's really similar to the Fifth Vital Sign campaign. And I think this is really interesting, because many of these campaigns were actually, integrated within, my curriculums. The fifth vital pain is the fifth vital sign. That's something that's really, common within medical or nursing type of curriculums. And so it really shows how much power these pharmaceutical companies had in infiltrating our decision making. And then the other thing I would like to discuss is this chilling effect, and this implied failure to prescribe would result in untreated pain. And Cephalon really tried to exploit the human fear of untreated pain, and they really tried to exploit this to push their product as a immediate acting opioid medication. So for some future research, so OIDA offers some really easily available data sets. This is one data set that I think is really interesting, and it would really look at this prescription data, just going back the 57 units per prescription. That's significant. So it would kind of look at what did these prescriptions look like. There's also that sales call data set to kind of look into different type of providers' fears. What did they like about this medication? What did they not like about this medication? And go into how what was the response when sales rep tried to approach them. We also need to look at the engineering design of pharmaceutical medications and their either abuse potential or their risk of a poisoning or overdose. A raspberry flavored fentanyl lollipop, versus another type of engineering design of a medication. And then, it also I think would be interesting to look into the FDA's responses. We have the medication was approved in 1998. Lawsuits didn't occur until 2008. Deposition was 2018. Labeling changes for specific side effects like hyperalgesia didn't occur until 2019. And for that particular side effect, it was Canada who went to, I think at the time it was Teva who bought Cephalon, and then really pushed for that label change. So some limitations. This data set, over 6 million documents. I'm a team of one, and this was a lot of fun for me. But I very likely missed some documents here. But I do think that the inductive approach was really useful in looking at different types of rare diseases like sickle cell anemia. So in conclusion, sickle cell anemia vaso-occlusive pain is a very pathological type of pain. And people who have chronic pain, who need opioid medications or non-opioid medications, they deserve access to a pain management system that prioritizes patient benefit over pharmaceutical profit. And we can also, in conclusion, we can also look at how the opioid crisis, affected different types of policy-making decisions, such as the 2016 CDC opioid prescribing guidelines. And that's all I have. So thank you so much for having me.
Excellent presentation, Coryn, and also fantastic presentations by all of our speakers. And now we are going to open up to a Q&A where I will be asking some questions as well as some people from the audience. So to get started, having had exposure to the documents, have any of you had new insights or become aware of industry behavior that you wouldn't have considered before, or did it reinforce your existing ideas already?
I guess I can jump in since I read many of the documents.
Mhm.
For me, I found the, you know, I'm very young, so in looking at these documents, it really contextualizes how significant the opioid industry really influenced clinical decision making, and how they really infiltrated curriculums, and it really brought forth into my brain of how did they do this? Like, how did they convince prescribers to prescribe medications when the data wasn't there? And that's, I think, the largest question I had was the data behind the scenes that they said they had, but they clearly didn't.
Thank you. That's a great response. Uh, Another thing that comes to mind for me, and I think Claire touched on this a little bit. Do you think the language that we, as well as the industry, uses around the opioid crisis influences institutional and public responses and attitudes?
Oh, absolutely.
Yeah.
I
Yeah.
mean, um, again, hearkening back to the early days of the realization of the impact of the prescription drug crisis. And it did such a disservice for it to be called opioids or opioid pills, because people were able to say, well, that's not us. And I think that played a role in with drug use being already stigmatized and connected to criminalization, and that being internalized, quite frankly, by a lot of Black communities, because it served a broader purpose of, kind of separation within the community, like hierarchies of who's important. But I early on felt very strongly that opioid was dog whistle for the white people we care about. And that it's also because there are the 3 FDA approved medications. Again, having seen it in HIV, when the medications become the answer instead of the broader issue of what is the um, societal context in which this health emergency is happening, it just becomes very convenient to break it down to the substance. And I just felt like that was such an incredible disservice. And I think we're still dealing with it today in trying to work with Black communities, wanting to work with Black communities, even early on in the HIV days. It was like the dominance of the drug policy propaganda literally drove the further spread. And both for HIV and opioid use disorder, you have to have a relationship with a provider who is non-judgmental, who understands you as a person who has sex, uses drugs or not, and that you don't fear their judgment or even worse, stigmatizing you further in your medical records. So unless it's a two-parter, it's fine that it's great that we have the medications, but the medications aren't going to be utilized if you can't talk to your provider about some very important aspects of your life.
It's to add just like another dimension too, I do some documents research around the opioids and in reading to inform my investigations. There was a paper I came across regarding the discussion of language around the opioid crisis and how looking at pain and addiction journals, there was a pattern of individualized language versus like more socialized language. So when discussing people with opioid misuse issues or talking about providers and their practices, usually what they found in this study was a lot of the focus on discussion as well as solutions would be formed around individual behavior and responsibility as opposed to addressing structural and systemic issues, and that language itself was playing a part in that. And I wonder if any of you had any thoughts or opinions around that.
Well, I don't want to take up all the conversation, but I will just say the social determinants of health was an interesting phrase that emerged during the I remember hearing it first in the early days of the protease inhibitors being used or being utilized, and it was almost like a phrase that healthcare providers used to identify the kind of annoying elements of their patients' lives, right? Reasons why they weren't adherent. And it just was a joke because it's like social determinants are people's freaking lives. What are you talking about? And that people order healthcare where it matters in their lives in relation to other elements of their life, which again is the problem that we have of having an addiction treatment system that is treating one part of you and one aspect of behaviors. And the behavioral health system, let me just put that into, I hate that term because most people are saying behavioral health and mental health. And, like we know they mean behaviors that we don't like, i.e., drug use and mental health, which is wholesome, organic. And if we're going to talk about behavioral health, then let's talk about smoking, let's talk about shopping, let's talk about gambling, let's talk about the whole realm of behavioral health and stop saying it with a sneer.
Thank you for that insight. I appreciate
Just
it.
quick question. What is somebody's asking about the CSA, and I've been trying to look up what is the CSA?
It's familiar in mind, but the acronym is slipping me at the moment. I can try to figure that out in a second.
Controlled
I was going to
Substances Act.
ask, go ahead, sorry.
It's a Controlled Substances Act.
Oh, yeah. Do any of you have any insights on that you'd like to share? Tracie, you're muted if you were trying to share.
I didn't hear what Amanda said.
The Comprehensive Substances Act was what was being
Controlled
referred to.
Substances Act.
Controlled substances, sorry.
Oh, yeah, that's another webinar.
Um, I haven't focused on that specifically myself, so I don't have too much to say. So we could potentially circle back around to that unless anyone has a comment. But Claire, I had a question for you. You kind of teed me up on it. If the archive itself were an historical actor, what would it say?
So I guess when I think about like all of these opioid uh, documents or all, industry documents, libraries, they're all like, I don't, um, and there was a very good question in the chat to say that, we were told as panelists, so everyone who's here, to humanize the archive, right? So this is literally like if it were a person, what would it say? But someone in the chat said, well, the archivists, right, are the voice of the archive. Like there are people who do the labor, who make the archive possible. So that's fair. Very good point. I don't know. When I think about these industry documents, archives, and they're hugely important in the history of public health. David Rosner, right, and his co-author Jerry Markowitz have written books and books and books based on, um, industry like litigation against industries that cause a lot of harm. And I think of these like troves of documents. I I think of them as like getting them and making them accessible, that they're like the Pentagon Papers or something. Like there's like a heroism around them, like taking on these like behemoth corporations, and then you make the documents um, publicly available, and they they paint the industries as evil villains because the people just say explicitly, it's like explicitly, it seems like explicitly terrible things. But I don't know. I guess something about the most recent presidential election, the current media climate, my students, and the history of medicine among African Americans class, when we were looking at the newly released documents from the US Public Health Service syphilis study at Tuskegee. Like I'm just not so sure that putting them all up there, we can all agree that like everyone will look at them and agree that they're bad, you know? Like is there a harm in people looking at them and viewing, I don't the corporate actors as coming back to this binary of like people being very hard for people to understand heroes and villains. And when we create an archive that is meant to set up villains, do we run the risk of people, I don't, looking at the flip side of that and seeing them as heroes? I'll also add that Amy Sullivan, the oral historian who was my co-author for the essay that we wrote on the Do Less Harm collection, if you read her book, Opioid Reckoning, which is all oral histories of the opioid crisis kind of unfolding in the state that invented rehab, Minnesota, in the 2010s. She says in that book that she's going to archive all those oral histories and make them public at the University of Minnesota. And I don't think she would mind my saying that we were just together at a conference. And she says she doesn't think she's going to do that anymore, in the sense of make them publicly available. Um, that that transparency, um, there are harms of transparency, even while there are benefits. And so, yeah, I mean, I guess that's what I don't know. Like, I think if the industry documents archives were talking, they would be like, I don't know, Mr. Burns in The Simpsons or something like that, like, um, and anyway, like, I'm not saying it's good or bad, but just like, could we think about it? I don't know.
I appreciate the Simpsons reference. I consider myself the old man shouting at clouds. Um, it's what do they say? History is written by the victors.
Hmm.
So a compilation of documents about a time in history that corporate capitalist interests, stepped on uh, the everyday ordinary human, and um, and that there was some, right, like, we have to be real about what are also the incentives behind acknowledging that degree of harm, right? Or
Hmm.
the fact that um, that states and counties, 80% of the opioid settlement funds are going to counties. And so if you could go to the county level, then you could have gone to the family level and the individual level. And just we have to acknowledge that no one on that side of the litigation, including the attorneys and the corporations, were going to give money to people who use drugs or families of people who use drugs, right? Because um, that's the inherent punishment and stigma of it, and it reinforces the stigma that even if you came forward to say this is how we were harmed, it discouraged it intentionally. um, and then I would also say one of the other reasons NBURN exists is to uplift the disappearance of voices who were critical in this work. So, and I call about the work of building health and wellness as structural to try to address the divestment, right? Because you take away from communities in a way that makes them more vulnerable to health emergencies, which is why I brought up Erica Dora's article in Washington Post about governing by emergency, because it's just layers of neglect and half-assed, investments or emergency responses that means that the communities as healthy cells cannot thrive. And if the cells aren't thriving, the body is not going to be well. And I don't know if it sounds like Black Lives Matter because everybody else's lives matter. And, it's the same way we think about women. If you ensure that women are healthy, like, that's international relief policy. If you are ensuring that the girls and the women of a community are healthy and well, the whole community benefits. So this isn't kumbaya. This is just survival. We need each other. And then we have to address that imbalance of the mass of us being corralled by the few.
Thank you. Appreciate that. Yeah, it's feels like oftentimes responses are band-aids to alleviate an immediate problem that don't actually get to the root of it. And then they persist uh unabated in a way. Um, so a question for all of you from the audience. Uh, how have you seen industry messaging normalize powerful opioids, and how are we seeing similar patterns with other products that affect public health?
I guess I'll jump in for this one. So I'm just going to think of an easy one that comes to the top of my mind that is controversial in talking about the harms, and that's social media. So we can kind of think about how, are these safety features, what are the benefits, what are the harms of them versus our social media companies bad? How do we define that? And what is the messaging, coming from, lawyers versus the companies themselves versus, teens or parents and how has that, changed? But it's also, interesting to think about, the responses of these social media companies and their defenses in these recent lawsuits, the bell ringer case, and just really look about like what was their defense. And I think that can also be, maybe that's something that we're not talking about enough. And thinking about how we can kind of like pick it apart as a public society and the opinion, like public opinion of these big companies and their response to, pretty, severe like severe accusations and with, data behind them.
Yeah, you actually reminded me about I've been learning about AI a lot lately, and AI psychosis kind of reminds me of like a developing thing of harm that companies are trying to actively minimize, but is like a real risk to users of those products. Um, Another question from the audience from Katya. This one's directed at Tracie. Can you speak to the superlatives of the worst drug epidemic language? It feels erasing of the crack epidemic of the 1980s that disproportionately impacted the Black community in the US. It feels like once substance use became a white epidemic, we gained compassion and a focus on treatment rather than criminalization. The main difference is the race of who was most impacted. What are your thoughts on that?
The same as yours. I mean, you know, I appreciate the organizers asking me to speak. I'm always grateful for any platform I can have to talk about these kinds of issues. And I'm old and I'm getting ready to I need to go sit in a corner and stop yapping. But I did bring up this is obviously not the worst opioid epidemic, and it's not the worst health crisis either. And just somebody also asked a question about like what's the HIV movement? Why was it so more effective than what's happening with drug addiction? And as someone who's interested in being able to chronicle the history of advocacy and activism in Black communities during the HIV epidemic prior to 1996, because that was the time I was there. Once the protease inhibitors were secured as the pathway toward, addressing viral replication and let's not forget that that's all of the PrEP. HIV PrEP is based on the mechanism that reduces transmission between mother and infant in utero, right? It's the same mechanism that we use or the same pathway. But in my observation, this is only my opinion, that once the protease inhibitors came out and once we started building a health infrastructure around it, the white gay men stepped out of the chat. And who was left were the Black and brown people and the drug users, right? And so, argue with me, I was there, and there was a distinct difference in the kind of activism, the entitlement to policy change to address these issues. And, How to Survive a Plague has a chapter yet to be written, which is how we survived this latest plague.
So another question from the audience. Is the medical use of archives such as Coryn has shown can be done a growing aspect of health/medical history, perhaps the next stage in your sequence of historiographical stages in the field, Claire?
So I skipped a lot of different subfields of health history, just to focus on sort of the great men and the reaction to the great men and reparative. But there is scientific or applied health history too, and that has a long tradition. One of my grad school advisors, Howard Kushner, wrote an article in the Lancet called "History as a Medical Tool." And so there are plenty of folks who do this and have done this work. So, but I think it depends. I would love to see it done. I would love to see this kind of work normalized. There aren't very many of us historians that teach in medical schools like I do, or teach in public health schools, or teach in nursing schools. And so again, say thank you to OIDA. Like, all of the work you've done on curriculum materials is bringing history into health professions education and working with historical documents in health professions education, um, which is necessary not just for like a baseline, establishing a sense of medical professionalism and like what is okay and what is not okay, but also shaping attitudes and clinical practices going forward. And so, yes, I mean, this is my my bread and butter comes from teaching would aspiring physicians, and so I'm very lucky as a historian to do that. But I would love to see a historian at every public health school, every nursing school, every medical school
And
doing.
social medicine. Like, I don't know if it's medical activism. I've been fortunate enough to be able to talk to some med students, because that's where it starts, right? Like, I'm a person with a drug use background, and I had major surgery on my foot, and I was happy to have the residents come in with the person who was about to perform the surgery, and I looked them square in the face and say, and yes, I have had a substance use disorder, and that doesn't mean I deserve any less pain relief. And you need to think about that for me and anybody else you see. Because it's at that, if you don't call it and name it or not be shamed by it, then it gets perpetuated. And I'm sure there's more teaching about addiction, but it's the same way it was in the HIV epidemic. You couldn't get the infectious diseases docs into the work until you incentivized it with better rates.
Well, I'm afraid we've reached the end of our time together today. I really want to thank Tanner for moderating this discussion, for all of our presenters, really, for pushing us to re-examine our perspective on history and on the opioid crisis today. Thank you, everyone who attended today. We hope to see you at future OIDA-sponsored webinars. All registrants for today's symposium will be added to our OIDA announcements list, and will receive the links to the recording of today's event and the entire symposium for this year. So thank you again for joining us today, and this concludes our symposium.